Hello, I'm Dr. Corey Maas, and today we're going to be talking about updates in cosmetic therapy using botulinum toxins. This is supported by grants from the American Academy of Facial Plastic and Reconstructive Surgery, as well as a grant from the Allergan Corporation, who donated video treatment demonstrations. And specifically, we're going to be talking about the new updates that have happened really significantly this year, 2009, with the release of Dysport, FDA guidance documents that have been released that demonstrate treatment strategies as well as patient education and consent strategies. And we'll be going over those as well as newer and improved treatment strategies for physicians, clinicians in general, for botulinum toxins. Want to start by just introducing the injectable neuromodulators and describing their mechanism of actions. There are, as most of us know, 7 serotypes of the botulinum toxins. Most of them are more scientific in nature. The two main ones that we see in clinical use are the botulinum toxins type A and B, and we'll be talking about those in just a moment. There's plenty of research being done on the other serotypes of botulinum toxins, but more specifically we're going to be talking about the A neurotoxins, or neuromodulators as I like to describe them, for the session today. Now, all of these work in the same way. They prevent the release of acetylcholine from the nerve terminal into the neurosynaptic cleft. And they do that by different mechanisms across this rather complex protein network that connects with the plasma membrane, or allows the docking of the vesicle to the plasma membrane. Specifically, the botulinum toxins prevent the release of acetylcholine into the neurosynaptic cleft, and thus muscles aren't able to contract or contract as effectively. They're relaxed. Now, the history of botulinum toxins are very interesting. Obviously, the original research was done as it relates to the disease botulism, which is caused by Clostridium botulinum. This was discovered, or at least the critical aspects of it were discovered in the 1950s. But to our interest, Dr. Alan Scott, who is not a mythical figure, he's a practicing ophthalmologist here in San Francisco, and I see him with some frequency, really had the innovative idea of using the very specific characteristics of this product to treat kids with strabismus. In other words, he thought if he could weaken a muscle that was over-contracted or spasming in an eye, causing cross-sightedness, that he could in fact improve the condition without extensive surgery. He received, after extensive research, approval for its use in strabismus, and has some very interesting stories about its history in general. And it was his observations that in treating later on blepharospasm, that wrinkles were improved, that really got the ball rolling with BOTOX. And in the early 90s, many of us began using the product and describing its use. Now, as I mentioned earlier, there are 7 serotypes of them. There are some similarities and differences between these serotypes. The one that we're specifically interested in is the A neurotoxin. But they are all clostridial products, proteins, and as I tell patients, they're naturally occurring proteins, and they will produce a flaccid paresis, which is reversible over time through body mechanisms that we've often discussed. There are some slight antigenic differences too. There's differences in these proteins, and as a result of that, there are different binding sites for the products and certainly different enzymatic actions of them. But in general, the A neurotoxins work on the SNAP25 molecule, and the B neuromodulators or neurotoxins work on the so-called VAMP or synaptobrevin molecule. Now, there are a number of products that have come to the market more recently. Myobloc in the not too distant past. We're all familiar with BOTOX Cosmetic, and I'll give you, of course, its history. But more recently, in 2009, Dysport was released or cleared by the FDA for use in this country. And as a result of that, there will be some profound changes in the way we think about treatment strategies for our patients, and we'll be talking about that today. There are other neuromodulators or neurotoxins throughout the world. They're listed here, and some of these we will never see in this country or unlikely to see for many years, those from China and South Korea. Ones that we may see in the future, which are in current clinical trials, include the BOTOX product that is formerly from Mentor Corporation. Mentor Corporation has now been purchased by Johnson & Johnson, so there's a very good chance that we'll see that in the not too distant future. And of course, Xeomin is a product which is a naked molecule, and I'll be talking about that a little further in detail. Which is from Maas Pharmaceuticals in Germany. And while it's approved in Germany, to my knowledge, there have been no trials initiated in the United States for cosmetic therapy using the Xeomin product. As I mentioned before, the Myobloc or type B neuromodulator is used and approved primarily for neurologic types of disorders such as spasticity. And we'll be looking specifically at the cosmetic applications and their very limited value for what we're doing. More recently, there have been some topical applications that have been attempted. Revance Therapeutics is looking at topical applications, which in my opinion may be fairly limited to the use in hyperhidrosis, specifically axillary hyperhidrosis. But those trials are underway, and it's yet to be seen how effective they will be for applications in cosmetic surgery and cosmetic treatments. Now, as I mentioned before, Myobloc, which is now owned by the Soltice Corporation, is interesting in that it's the only one that comes as a liquid formulation. And the reason they're able to prepare it in a liquid formulation ready to be drawn out of the vial and used is because the pH is kept quite low. Now, that keeps it stable, but at the same time, it makes it more painful with injections, and that was a big shortcoming of this in the clinical trials that we conducted at UCSF a number of years ago. Our final conclusions on this was that the product itself had a very profound clinical effect in terms of smoothing the forehead or brow area or other areas treated, but that clinical effect diminished quite quickly within 4 to 6 weeks after the treatment, even at very high dosage levels, 2,000 to 3,000 units per treatment area. So the duration was much less than the A neurotoxins or neuromodulators, and even then at those high doses in multiple treatment areas, patients began to report some autonomic side effects such as dry mouth. So its real clinical use for aesthetic applications is very limited, and I don't think many of the experts are using the type B neuromodulator Myobloc. BOTOX Cosmetic, which we're all very familiar with, was released under the Cosmetic label in 2002, and of course it was around many years before that, with many of our aesthetic applications being developed before it was even released under that Cosmetic label. It's a botulinum toxin type A. Its new name under the FDA guidelines is ONA botulinum toxin type A. That'll be the new generic name for this product for BOTOX, and it's supplied in a 100-unit vial of lyophilized powder. Typically, it's reconstituted in 1 to 4 cc's or with 1 to 4 cc's of saline, bacteriostatic or non-bacteriostatic. There's a lot of discussion about which is better. I'm not sure that it matters one way or the other. The peak of the bell curve in terms of choosing reconstitution volumes is 2 to 2.5 cc's, with the high end of that bell curve being 4, the low end being 1. Most clinicians are using 2 or 2.5 cc's of diluent, the saline, to reconstitute the powder. We use a number of different types of syringes. Now we've gone to hubless syringes when we're doing the injections. I'll show that in a few minutes. It certainly should be refrigerated when it's reconstituted. Proteins are more stable when they're kept chilled. And while the package insert says that it should be used within 4 hours, I think most of the data supports its use within a week or two, showing no significant loss in its specific bioactivity. The clinical trials that were done with BOTOX were designed really after much use of the product for cosmetic applications was well underway. And as a result, I think the FDA's bar for approval was much less than it might have been otherwise. But as you can see from these data slides, this is really a statistician's dream when you have a placebo line like this, and you can see this is the number of days here across the axis, and then the abscissa, the number of patients that were considered responders. That's people who went from moderate or severe lines between the eyebrows to those that went to none, really, or mild lines. And as you can see, it's just really consistent with what we've seen in clinical practice. These are highly statistically different. By day 7, all these patients, almost 80% of them were considered responders, and that duration of effect lasted, at least for 50% of them, almost out to 90 days for these patients using Botox Cosmetic versus placebo. So very dramatic and profound results seen with that. Now that was the investigator assessment, and when you compare those to patient assessments of these frown lines, you can see that the curves are almost identical. Placebo, virtually no response out through day 90, and when the patients were asked how they feel about it in terms of the severity of their lines, you can see that, very high proportion of responders, those are people who went, again, from severe or moderate lines to none or mild lines, stays very, very high. And again, those are the kind of statistics we all like to see with any therapeutic type of medication. In terms of the safety of Botox, as I tell most of our patients, the safety profile for this drug is better than that of many drugs we see, like aspirin. The side effect profile of these drugs are really barely different than placebo, with one striking exception, and that is this incidence of ptosis, which we know is often described as a diffusion-related side effect, and we'll talk a little bit about the mechanisms of action of ptosis, or at least our theories on why it occurs. But in those trials, the ptosis rate was 3.2%. I think most of us know from our clinical experience that ptosis rates are much, much smaller than 3.2% with experienced injectors. This is very, very unique, of course, to clinical trials and the experience that's reflected in those trials. Dysport is the product that was approved in April of 2009 by the Food and Drug Administration. It was really released for use not until June, so the clinical experience with it is pretty limited. I will reflect my experience with it, and we did 5 years of clinical trial testing with the product. Initially, it was going to be released as Relaxin, as many people know, and Medicis has the exclusive United States rights for its distribution. It is a lyophilized product with 300 units per vial, and the distinction between it and Botox is that it's in a lactose carrier, so there's a little cube of powder that one might see at the bottom of the vial when it's delivered. I should also mention that under the new guidelines for generic labeling of these, and this is a very important issue for the FDA, it will be called ABO, botulinum toxin type A, in contrast to ANA, botulinum toxin type A for Botox. So Dysport is ABO, botulinum toxin type A, and Botox will be ANA, botulinum toxin type A. Now, the clinical trials with Dysport were a completely different design than Botox, and that was because this was a de novo application to the Food and Drug Administration, where the product hadn't been prior approved for functional applications. As a result of that, some almost 3,000 patients were enrolled in these trials, with 5,000 treatments over a 5-year period. And we were involved in most of those clinical trials that were specifically directed at the glabellar treatments. This is the treatment of the frown lines between the eyebrows. So the data that I'm reporting for Botox Cosmetic as well as for Dysport are those data that were generated for glabellar applications. Any other application that we'll be talking about today are considered by the Food and Drug Administration to be an off-label use of these products. With the Dysport clinical trials, you can see that the efficacy of a single treatment, and this was the placebo-controlled single-dose clinical trial, that the median duration of response was 117 days, almost 120 days, which is a little bit different than what we saw with Botox Cosmetic. It seems that it's about a 30-day longer response, and again, this is specifically the glabellar area, and it may have something to do with the trial design, which I'll comment on later, to be fair for both of these companies. When we superimpose the clinical trial data for Botox Cosmetic against the Dysport clinical trial data and look at duration of response, there's some interesting findings. First of all, there were early days captured between the two of them. Both of these products have an onset. We're going to talk about onset of action in just a moment. Most of us accept that 3 to 5 days for clinical onset of activity is sort of average for Botox Cosmetic, and I'll talk a little bit more about the Dysport data because the only data generated for Botox was the data from day 7. But if we look at it at day 30, we can see the vast majority of patients are considered responders, which means they went from moderate or severe in the treatment of their glabellar lines to none or mild. And with the Dysport in the lighter line, it's 90% or about, and BOTOX, it's 80-some%. And as you go on to day 60, you can still see a very significant proportion of responders. By day 90, this is dropping down below 50 for BOTOX, but very close, 50 or 60% for Dysport. And day 120, there are still responders. Interesting, there's this outlier out here, but you can see that nearly 20% or more, or 25% of patients treated with Dysport have durations of effect out to day 150 or 5 months of duration, which is really significant. Why is there no BOTOX data there? Well, we need to generate that data because their initial trials didn't look at data out in those areas, at least they weren't reported. So with Dysport, if you look at the percentage of patients that were responders from a single treatment, it's very similar to the curves that we see for BOTOX, with the exception being that nearly a quarter of patients at 25%, or a full quarter of the patients, were considered clinical responders at 5 months of after their treatment. This is significant for all of us, as it suggests there may be slightly longer duration of effect. Now, to be fair, I have many patients that get BOTOX on a 4 to 6 month treatment interval, and many of them do believe that the treatment lasts that long. So I think what it speaks to is the need for ongoing clinical data that will look at sort of the spread effect of how many patients will get a treatment that lasts the average, what we've talked about with BOTOX, for 3 months, and how many patients actually could expect to go out 5 months and beyond. We know that now for Dysport, about a quarter of them will, but there is no controlled clinical trial data looking specifically at that for BOTOX Cosmetic. The other important aspect of this, and these are some subtle clinical distinctions between Dysport and BOTOX, is the onset of effect. As you can see from this chart, nearly the majority of patients, in fact, notice a significant clinical onset by day 2, and we do know that that is slightly earlier than BOTOX. I don't think it would make a difference in a clinician or a patient choosing one product or another, but it is a characteristic of the product that it seems to have a faster onset of action. Now, when asked why, I don't know. The answer is we can make some hypotheses about that. The naked molecule is identical, but the surrounding hemagglutinin and non-hemagglutinin proteins around these molecules are slightly different, and that may impact the onset of action. Maybe it works a little faster, maybe it's taken up a little more quickly at the neurosynaptic cleft for one product versus the other. So interesting that the onset of action is slightly sooner with Dysport, probably about 2 days on average. And again, we don't have clinical trial data that proves this with BOTOX. It would certainly be worth generating onset of effect data. This next slide shows that the evidence of this earlier onset doesn't change with repeated treatments. In other words, the patients went through several cycles of treatment. They were treated, returned to baseline, they were retreated, and over multiple treatments, the onset of effect stayed statistically, and the curve stayed basically identical, as you can see here, through all cycles of treatment. The safety data on this, and I think a lot of people are interested, we're very comfortable with the safety data from BOTOX Cosmetic. It's been out there a long time. We all have a lot of clinical experience, so everybody wants to know about the safety data from Dysport. Well, as I said before, the Dysport trials were vastly more extensive than the BOTOX clinical trials, with nearly 5,000 treatments done. And the tolerability in both repeated treatments and single treatments showed that they were very well tolerated. There were no development of blocking or neutralizing antibodies, any antibodies for that matter, to the toxins. So we were very comfortable with the safety with the Dysport as we looked at this clinical trial data. And I published a paper with Dr. Moy about this, and I encourage you to take a look at that study. Of course, the most important safety data that at least we see with any frequency in our clinical trials is as it relates to ptosis. And while eyelid ptosis is very infrequent, if you do enough botulinum toxins, you will see, or botulinum neuromodulators, you will see some incidences of them. As you can see from this data, the study showed a 1% incidence in the 718 study, slightly higher in the 719, and then lower again in ongoing studies. but the combined overall incidence of eyelid ptosis was 2.1%, and if you reflect back on what we talked about from the Botox clinical trials, it was about 3.2%. So I don't know that these data are statistically different. It's slightly less for Dysport than it is for Botox, 2.1 versus 3.2, but I think the conclusion is that it's not very different in terms of this effect of eyelid ptosis, which I think was an early concern because of the rumors about spread or localized effect. Now, there have been some head-to-head, or at least one head-to-head study, which was a study conducted by Dr. Lowe, and he looked, it was a double-blind study of 62 patients, 31 received Botox, 31 received Dysport, 20 and 50 units respectively. He followed the patients out for 4 months and used pretty standard reconstitution volumes and volumes of injection, at least as reported. The results of the Lowe study are interesting because what they showed was first of all, for both products, a much lower incidence of responders than we would typically think of. You can see the numbers here in the 50 to 60 range, which is very atypical by day 20. And this degrades quite rapidly for both products. But most interestingly, by about day 90, as you can see here, on the red Botox curve, the patients suddenly got much better between the 60-day therapy and the 90-day therapy. And most of us know that people aren't getting worse and then getting better with these treatments. I think it's hard to interpret these data because of these erroneous data points here, and I think even Dr. Lowe has admitted that there may be some issues with how the grading was conducted. It is the only head-to-head study. It was done in different patient groups, which need to be age-matched and matched for gender and for skin thickness and other things, and that may have some impact on how this grading was done. But certainly head-to-head trials should be done before any conclusions are made about efficacy or duration of effect in a comparative way. I've shown you what they look like if you just take the package inserts out of the products and put them up side by side, but really split-face studies are needed. Now, in terms of dose equivalence, a couple of things need to be said. The first one is that, as most of us know, units of botulinum toxin cannot be compared one-to-one. The way that these things are evaluated is by their specific bioactivity, in other words, the potency of the product. There is so little product in each of these vials, the active product, that it's impossible to weigh them. So it's not like we can give a milligram of Botox or a half a milligram. These are nanogram amounts. And so the only way to really measure the amount of active product is by these specific bioactivity tests, which are done in rat models, and their variation is based on the type and size of the rats and the breed of rats, and etc. So one cannot compare 1 unit of Botox to 1 unit of Dysport and make any conclusions about it. And in fact, most of the studies that have been done support a 2.5 or 3-to-1 ratio, in other words, of Dysport units to Botox units. 1 unit of Botox is about the same as 2.5 or 3 of Dysport. And that's really the way the clinical trials were conducted for Dysport. In fact, if you look at the graphs, the 2.5 or 3-to-1 ratio, one sees that there's not very much difference in the outcomes when treating the glabellar region. And that's why they chose the 50-unit dosage for the glabellar area when using Dysport, much as Botox or Allergan chose the 20-unit dose for the glabellar area when using Botox. In our practice, we're starting with this 2.5-to-1 ratio. I think there's a good argument that can be made to go slightly higher, and it will take a little time for us to determine which is a better sort of ratio. In the end, we'll be using about 50 units in the glabella, maybe 60. In the end, we'll be using about 50 units in the orbicularis muscle, maybe 60. And in the forehead, we'll be using somewhere in that range, 25 to 30 units for most patients' forehead, unless you want to get a lot higher. And we'll be talking about dosing indications later, but I just think it's important to understand, and this is an FDA guidance issue, is that these units cannot be transposed one-to-one, and you have to be very careful in your office to make sure that you're keeping the products separate when you're using them. So those are the two main cosmetic products that we've talked about in terms of their physiology, the clinical trial data that's been generated from them, and what we know about them so far in terms of reconstitution and dose equivalence. The newer products that are still on sort of online include the PureTox product from Mentor, and this is a University of Wisconsin developed product which is a highly purified toxin. We've been involved in the clinical trials. Again, this is now owned by Mentor, and subsequently Mentor has been purchased by Johnson & Johnson, and I have worked as a clinical investigator and as a consultant for these companies as well as the other ones. The phase 1 data from the Mentor study showed very good wrinkle improvement. These were basically safety studies that made sure that there was nothing significantly wrong with the patients. The phase 2 studies, and these are still in FDA trials, so we're limited as to what we can talk about in unreleased data by the FDA. But when we looked at the assessment of these patients using these validated photo scales and evaluation of patients over time, when one looks at the clinical trial data generated from the PureTox, which has been published and is available to us, phase 2, early phase 3 trials, one can see at the 30 dose unit range, there's a very good curve at day 30 here. Nearly 100% of patients are responders. The data from BOTOX, again, was about 80%. Whether this was a measuring tool error or actual, I think most of us agree that patients get good responses earlier. And as you see at day 60, this stays on, and by day 90, the curve is very, very similar to that we saw of BOTOX, and earlier on even a little higher, more like Dysport. Our conclusions about this, at least those that I can just say from looking at the clinical trial data that we can talk about, is that the product seems very, very similar to BOTOX. In fact, a little more similar than the Dysport product. And just some examples of patients that have been published from the PureTox trial. Clearly, day 0, 3 early onset, and day 7, a nice clinical effect, as you can see from these men and women patients. Day 0, day 3, obviously an effect maybe earlier than what we saw with BOTOX, and by day 7, a good clinical effect for these patients. The other product that is still, still not in trials is Xeomin. Now, Xeomin has been approved in Germany, is widely used there. There are subtle differences with Xeomin. It does not have the surrounding hemagglutinin and non-hemagglutinin proteins. So, in the process of developing the botulinum toxin type A Xeomin, the company actually removes these surrounding proteins, and so you basically have the naked active molecule of botulinum toxin type A. Again, trials haven't been started in the United States for cosmetic applications. I imagine they will be soon, but Dr. Fritsch from Germany has published her data looking at glabellar and crow's feet areas, and these are available, and clearly there is a good response with this product. So I think it's one that we may see in the future. It's certainly a product that has some interest to us, and we will be seeing other neuromodulators or neurotoxins coming forward. Now, getting to the meat and potatoes of what everybody wants to know about BOTOX and Dysport and how we use them, I think it's very important